All right. Hi, my name is Megan Rudder, and I am a faculty member in the Division of Women's Health and Department of Medicine at Brigham and Women's Hospital. And I'll be speaking today about common medical concerns or questions that arise in the hospitalized pregnant patient. And some of the issues that I'll address today pertain to patients very early in pregnancy who might be admitted primarily to medicine, and others pertain more so to consults from the OB team. What I found over the years is that even the best medical minds tend to go a little bit blank around pregnant patients, and often fear sort of takes over. And I think this is largely because of lack of exposure, experience, and training. So we defer to the OB team. But more often than not, they're looking to us to evaluate or manage the medical concern. They have the obstetric differential on lockdown. So when they call you, they're looking for your medical take on differentials, diagnostics, or medications that might be less familiar. So I hope after the next hour or so, you'll feel more comfortable and confident managing pregnant patients with medical problems. For a little bit more background about why I, as an internist, am covering this topic. This is my training. I did internal medicine residency at Brigham and Women's Hospital, and then went on to do a 2-year obstetric and consultative medicine fellowship at Women and Infants Hospital in Providence, Rhode Island. And I now run an obstetric internal medicine consult clinic at Brigham and Women's. I have no disclosures. I do have a few disclaimers. This discussion will focus on care of cisgender pregnant women because this is where the majority of data lies at this point. This is a very broad field. I'm going to focus on a couple of specific topics that were requested for this talk, and then I might use the terms baby and fetus interchangeably in this talk. Before we get into the specific topics that we'll cover, there are a few general principles that are really important to keep in mind when we're caring for pregnant patients. And if you remember nothing else, remember these points. So fetal well-being depends on maternal well-being. And this is important to remember not only as a treating clinician, but also sometimes to remind our patients. They can't sort of sacrifice themselves for their fetus because the fetus is dependent on them. And this carries forward to the principle that uninvestigated symptoms can lead to progression of untreated disease. And from there, uncontrolled maternal disease can compromise fetal safety, growth, and development. Generally speaking, we see more harm done from withholding treatment or diagnostic testing that is clinically indicated than by pursuing those things in pregnancy. And lastly, we should really be thinking about interventions like medications, imaging, and procedures in pregnancy as justifiable versus not justifiable, rather than safe versus not safe. Now into the specific topics that we'll talk about. We're going to cover hyperemesis gravidarum, hypertensive disorders of pregnancy, pyelonephritis, pulmonary embolism, and very briefly touch on procedures in pregnancy and diabetes. So jumping into hyperemesis gravidarum. In approaching hyperemesis, it's crucial to first understand nausea and vomiting of pregnancy. So nausea with or without vomiting affects up to 90% of pregnancies. It's very common. And the critical piece is that it's due to pregnancy rather than other pathologies. So this requires us to have sort of normal vital signs, physical exam, and labs. Symptoms should also follow a typical timeline. So they should start around 5 to 6 weeks of gestation, peak around 8 to 9 weeks. If symptoms are starting after 10 weeks, we should really be thinking about other etiologies. And for a majority of patients, symptoms resolve between 12 and 16 weeks, although 20% may continue to have symptoms through 20 weeks, and an unfortunate 5% may have symptoms until delivery. It's also helpful to know that higher HCG levels are associated with more prevalent and severe nausea vomiting. Interestingly, recent research has identified the placenta and appetite hormone gene, GDF15, as the greatest genetic risk factor for hyperemesis gravidarum, but that's not something that we can assess or target in clinical practice yet. So we've established that not all nausea vomiting of pregnancy is hyperemesis. Hyperemesis is the severe end of the spectrum, and it's significantly less common. It affects only 0.3 to 3% of pregnancies, depending on the study and definition. Some of the variability is because there's been difficulty in coming to a consensus on the definition. Most commonly, definitions included a certain amount of weight loss, ketonuria, and one definition requiring vomiting more than 3 times a day. More recently, though, an international group came to a new consensus definition that attempts to sort of simplify this and prevent patients from getting to a point where they're in dire straits before we treat more aggressively, as we do in hyperemesis. So this new definition includes symptom onset less than 16 weeks, nausea vomiting that is severe and there's no more objective criteria offered for that, patients unable to eat or drink normally, and significant impact on daily activities. There are a few features of nausea, vomiting, in pregnancy that should raise red flags to consider alternative diagnoses. So hematemesis is unusual, should prompt consideration of upper GI ulceration or, in the appropriate clinical context, varices. Abdominal pain is less frequent but can happen. So we should be thinking about, again, peptic ulcer disease, pancreatitis, cardiac pathologies, biliary disease, gastritis or appendicitis, DKA, things like that. And then significant weight loss is certainly a hallmark feature of hyperemesis, but really shouldn't be present in run-of-the-mill nausea, vomiting, in pregnancy. Neurologic symptoms should prompt consideration of cerebral venous thrombosis or other CNS pathologies we'll see on subsequent slides. And fever should, of course, prompt evaluation for infectious processes. So when we're seeing a pregnant patient with nausea, vomiting, and likely a severe case, given that you're all practicing inpatient, it's really our job to remember that pregnant patients are allowed to have any problem a non-pregnant person has, as well as some specific to pregnancy, and to really consider and exclude relevant pathologic causes of nausea, vomiting. So this is a really broad differential to keep in the back of your mind, broken down by system. So we have gastrointestinal causes, genitourinary causes, metabolic causes, neurologic causes, some miscellaneous causes, and then your pregnancy-specific causes. I'm going to move to the next slide. This is a long list. I've highlighted some of the more common causes that we see masquerading as hyperemesis or nausea, vomiting, in pregnancy. I'm not going to go through these in detail now, but include this slide for your reference. Okay, so here I've listed some of the initial diagnostics that I consider in a pregnant patient presenting with significant nausea, vomiting, related to evaluation for the underlying pathologies that we just went through very briefly. And again, another reference slide that summarizes the physiologic changes in some of the more common labs during pregnancy, and we will go through these step by step in more detail. So when we're looking at a metabolic panel in pregnancy, sodium, potassium, magnesium, bicarb, BUN, and creatinine all normally decrease, and these changes become more pronounced as patients get farther along in pregnancy. That being said, when I'm looking at a BMP in nausea, vomiting in early pregnancy, I'm always careful to still consider hypovolemic hyponatremia rather than immediately attributing the hyponatremia to pregnancy physiology. I try to stay attuned to inconsistencies in derangement. For example, we've had patients with high normal potassium in the setting of significant nausea, vomiting, weight loss, who ultimately had Addison's disease. And then I also want to be mindful to assess the anion gap corrected for albumin, since albumin decreases in normal pregnancy and then even more dramatically in hyperemesis. A note here that hypochloremic metabolic alkalosis is quite common in hyperemesis, so you want to be sure to check for concomitant metabolic acidosis that might suggest starvation ketosis, which is more common in pregnancy. In terms of LFTs, we want to remember that the upper limit of normal for AST and ALT in young, healthy patients should really be 20 to 30, and these generally decrease in pregnancy. Alk Phos is made by the placenta, so elevation is normal in later pregnancy, generally after the first trimester. When we're looking at LFTs in the context of nausea, vomiting, we want to know that LFTs can be abnormal in up to 50% of patients who are hospitalized for hyperemesis. And generally in this case, the ALT is greater than the AST and the elevation is quite mild, within 2 to 3 times the upper limit of normal. In hyperemesis, total bili, both direct and indirect, may also be elevated, but that total rarely exceeds 4. When we're looking at a CBC, we want to remember that pregnancy can cause a physiologic leukocytosis with the upper limit of normal white blood cell count rising by trimester to peak close to 17 in the 3rd trimester. Hemoglobin and platelet count also decrease because of hemodilution of pregnancy and increased platelet consumption, again, more dramatic as pregnancy progresses. And then I find it helpful to look at a patient's historical trend of white count in pregnancy and the diff to sort of differentiate between pathologic leukocytosis and in normal pregnancy, the diff should be normal or show a slight neutrophil predominance. In hyperemesis, we can see a higher lymphocyte count. We might also be looking for hemoconcentration as a marker of dehydration in hyperemesis, but we try to keep in mind the physiologic anemia and lower platelets of pregnancy can mask this. Hyperthyroidism or thyrotoxicosis might be on your differential for a patient with tachycardia, palpitations in the setting of nausea, vomiting. We want to keep in mind when interpreting TFTs in this setting that TSH can be suppressed in early pregnancy because high HCG has thyroid stimulating activity. And because of this association between hyperemesis and high HCG levels, 30 to 73% of patients with hyperemesis will have abnormal thyroid function tests in early pregnancy. The way that we sort of differentiate between physiologically suppressed TSH is with absence of typical signs and symptoms on physical exam and generally normal or minimally elevated free T4 and T3. In patients with epigastric pain in the setting of nausea and vomiting, a lipase might be sent. And just know that lipase can be elevated in 10 to 15% of patients with hyperemesis gravidarum in the absence of pancreatitis and can increase to as much as 5 times the upper limit of normal. If we're thinking about features that differentiate between acute pancreatitis and hyperemesis with some abdominal pain is typically less of a prominent feature of hyperemesis or improves with a GI cocktail or antacids. An abdominal ultrasound should show no abnormalities of the pancreas. And if there's a lot of clinical uncertainty, MRI can be used. In pregnancy, normal acid-base status is different. So there's a chronic respiratory alkalosis that's driven by increased minute ventilation and results in a decreased PaCO2. Here, there is some renal compensation that results in the lower bicarb that we already talked about. I've listed here normal ranges for ABG and BBG in parentheses. In patients with nausea, vomiting, and evidence of metabolic acidosis on chemistries, I do generally get a BBG because acidemia is poorly tolerated by the fetus, so important for us to identify and quantify. I also generally send a lactate and a beta-hydroxybutyrate. Beta-hydroxybutyrate, even in the absence of diabetes history or elevated blood sugars, because in pregnancy, there's an increased risk of starvation ketoacidosis, more common in the third trimester and in patients who've had bariatric surgery, but can happen in patients without these risk factors. Okay. In terms of management, the first priority is fluid and electrolyte repletion. So we start with resuscitation with IV fluids without dextrose as you would in a non-pregnant patient. Then we want to replete electrolytes intravenously, again, same as you would in a non-pregnant patient. Then, because there is risk of Wernicke's encephalopathy developing in patients with hyperemesis, we do give IV thiamine for at least 3 days or until the patient is tolerating oral intake. Once initial volume status is replete and electrolyte and thiamine repletion is underway, we can switch to maintenance IV fluid with 5% dextrose. Usually this is given at a higher rate than in non-pregnant patients because there's significant plasma expansion in pregnancy and generally lesser prevalence of renal dysfunction and heart failure, and because there's often still ongoing loss via emesis. Of course, we want to be careful if we're giving dextrose at a high rate in patients who have type 2 or gestational diabetes to monitor blood sugars, and we'll talk more about that management later. It's also reasonable to add a multivitamin, folic acid, and B6 to their IV fluid if available. And then a short period of gut rest can be helpful for some patients, whereas others might actually feel as though it exacerbates their nausea. Regardless, a patient should be monitored for refeeding as they're started on dextrose-containing IV fluid or as they begin to eat again. Okay, so there are 2 ways to approach pharmacologic management of hyperemesis, as a delicate titration or with a more aggressive sort of sledgehammer approach. There's not much that's delicate or predictable about pharmacologic antiemetics in hyperemesis, and so it generally does require us to be more aggressive. I think just sort of a general pearl here, what is often emphasized with medication use in pregnancy is the lowest effective dose. And I think we focus often too much on the lowest piece rather than the effective piece. So we need to keep in mind that exposing patients to subtherapeutic doses or regimens of medications exposes them to fetal risk, without giving the maternal or fetal benefit of a truly therapeutic medication. So we want to avoid that. In terms of agents, it's not infrequent that you might have a patient on 2 standing antiemetics and a third is needed while in the hospital to gain initial control of symptoms. Generally, I'm reaching for an antiemetic from each of these classes, opting for an agent, the agent that the patient feels works best, and then liberally using adjunctive agents. So in terms of antihistamines, diphenhydramine is what we most commonly use. Within the dopamine antagonist, we generally reach for metoclopramide first, given it has more safety data. And then we want to remember that each patient is different. So some patients might actually feel that metoclopramide exacerbates their nausea. So reasonable to try prochlorperazine, which can also be given rectally, which is helpful. And if those fail, promethazine is sort of last resort, certainly as an IV route, but can be used rectally or IM. Serotonin antagonists can also be used and are used liberally, ondansetron being the most common. You might have heard a controversy about ondansetron use in pregnancy. One of the largest studies that looked at IV Zofran use specifically for almost 1.9 million pregnancies in the first trimester showed no effect on cardiac, oral cleft, or overall malformation. So we can use that confidently in the inpatient setting. And lastly, in terms of adjunctive agents, I have a really low threshold to use these because studies suggest that concurrently treating any component of reflux or gastritis significantly improves nausea therapy. So I typically start with H2 blockers, and since I have more data in pregnancy, and then escalate to IV PPI if needed. Some patients find benefit with sucralfate, others feel more nauseous when they're using it, so we sort of try if they're willing and then follow their lead. When all else fails and you're sure that you've ruled out alternative etiologies, we use a steroid burst and taper. I just want to emphasize that if you're opting for steroids, you really want to be sure you've ruled out other processes. You also want to be sure that you're monitoring blood sugars in patients with type 1 and type 2 diabetes, prediabetes, or history of gestational diabetes, because high blood sugars are actually teratogenic. And then if nausea vomiting is truly refractory, TPN or NG tube can be considered, but TPN in particular comes with risks, including thrombotic complications related to indwelling lines, given the prothrombotic nature of pregnancy at baseline, and then the dehydration and hemoconcentration of hyperemesis. So it's really a last resort. Overall, we want to keep in mind in this acute phase that hydration is more of a priority than calories or nutrition. Then let's say that you've made it through the initial phase and your patient is beginning to tolerate some food. We don't want to stop all IV agents cold turkey with their first bite. It's best to cross titrate from standing IV to standing PO medications one at a time, ensuring that the vomiting doesn't recur with each stepwise change. So as we're transitioning to orals, we want to keep as needed IV antiemetics available. And then I continue some standing oral regimen, generally whichever agent the patient feels is most effective for until the patient is reliably eating without vomiting. We can then add doxylamine and pyridoxine, which is first line for nausea, vomiting, and pregnancy, but that won't be enough alone. Generally, patients should be discharged on a standing oral regimen with additional as-needed oral agents to be continued for at least 1 week of stable PO intake in the outpatient setting, or sometimes we just say through the first trimester, because otherwise they do have a fairly high risk of rehospitalization. Here are certain dietary interventions that we can see help ease nausea, vomiting, and pregnancy as well. I'm not going to go through these one by one for the sake of time. So overall, key points we want to remember about hyperemesis. Not all nausea, vomiting, and pregnancy is due to pregnancy. We want to prioritize volume resuscitation, electrolyte correction, thiamine supplementation in patients coming in with hyperemesis. Treatment usually includes multiple IV, intramuscular, or rectal antiemetics and slow transition to oral antiemetics. We need to expect that patients will need at least 1 week of standing oral antiemetics after discharge. We want to involve nutrition early and often, and remember that pregnant patients are at higher risk of starvation ketoacidosis. All right, so moving on, we will talk next about hypertensive disorders of pregnancy. I'm going to start by revisiting preeclampsia definitions. So preeclampsia is a multi-system inflammatory disorder that happens during pregnancy or within about 6 weeks postpartum. And it's characterized by diffuse vasospasm, endothelial dysfunction, and microthrombi formation. And we'll talk more about the definition of preeclampsia compared to other hypertensive disorders of pregnancy. But really, I tend to think about it the way we think about hypertensive emergency, because this makes it easier to identify the organ systems that preeclampsia can affect. So we're thinking about the brain, the eyes, the heart, the lungs, the liver, the kidneys, and then the fetus as an end organ as well. Preeclampsia, as I mentioned, sort of falls along what we think of as a spectrum of hypertensive disorders of pregnancy. So there are a few different categories, and they're largely defined by the timing of onset of high blood pressure and association with end organ involvement, the organs that we just mentioned. So this is a flow chart that I think is helpful in visualizing the differences between chronic hypertension, gestational hypertension, and preeclampsia. So the common feature here is our old school definition of hypertension, that blood pressure of 140/90 or greater, and we can see the OB world hasn't yet sort of ascribed to the 2017 AHA-ACC updated definitions of hypertension. But of course, if a patient has a diagnosis of chronic hypertension based on this criteria before pregnancy, that still applies in pregnancy. And then the first point of differentiation is timing of onset or first recognition. So if this happens before 20 weeks gestation, this is considered chronic hypertension, though patients are still at risk of developing preeclampsia. If this happens at 20 weeks or later, we need to further differentiate whether there's evidence of end organ dysfunction, meaning the following. So abnormal proteinuria, or preeclampsia, importantly, no longer requires proteinuria for the diagnosis. So other evidence of end organ dysfunction that we look for: renal dysfunction, thrombocytopenia, elevated AST or ALT, pulmonary edema, or cerebral or visual symptoms. And if there's no dysfunction, then this is considered gestational hypertension. This is a busy slide that summarizes the different hypertensive disorders of pregnancy, and I just want to highlight here, preeclampsia with severe features is defined by what we call in pregnancy severe range blood pressure. So a systolic blood pressure of 160 or greater and a diastolic of 110 or greater. And this can be confirmed over a short interval because you need to treat this quickly. Alternatively, you don't necessarily need to meet blood pressure criteria to have severe features. You can have the initial preeclampsia diagnosis that we already defined, and then more severe end organ dysfunction that buys you the severe features diagnosis. So thrombocytopenia with platelets less than 100, AST or ALT elevations more than 2 times the upper limit of normal, severe persistent right upper quadrant pain that's not attributed to anything else and not responsive to medications, renal insufficiency defined as creatinine greater than 1.1 or 2 times the patient's normal, new headache that's unresponsive to medication, or visual disturbances, or pulmonary edema. When we're getting called about a pregnant patient with hypertension, usually it's for one of 2 reasons. One, the patient has failed initial therapy with antihypertensives and the team is calling for assistance with a drip or alternative oral agents, or the patient has atypical features for preeclampsia and they're looking for sort of assistance in thinking outside the box about the cause of hypertension. So we have to keep in mind the imitators of severe preeclampsia. These first 2 are items that most OBs will have on their radar and be thinking about since they're pregnancy specific. So HELP is hemolysis, elevated liver enzymes, and low platelets. And then AFLP is acute fatty liver pregnancy. We'll talk about these in a little bit more detail in subsequent slides. But really what we bring to the table as internist is consideration and recommended evaluation for other entities like other causes, typical causes of secondary hypertension or TTP in the appropriate context, atypical HUS, lupus flare, catastrophic antiphospholipid antibody syndrome, HSV hepatitis, certain arthropod-related infections, or drug use. This is a nice summary table that helps differentiate between the features of most of the severe preeclampsia imitators we just mentioned. I borrowed this from an article about thrombocytopenia in pregnancy. And again, I'm including this more for reference since we don't have time to go through the differences among presentation features for each imitator. So I said we talk a little bit more about HELP, and there's not clinical consensus among experts on the diagnostic criteria for HELP, with the main differences being in lab criteria to establish the presence of hemolysis. So ACOG uses just LDH, and the Tennessee classification uses LDH in addition to other lab markers that internists often use to assess for hemolysis. And then, as the name suggests, elevated AST and ALT and platelets less than 100,000 are also part of the criteria. Touching on acute fatty liver pregnancy, the name is somewhat benign sounding because fatty liver disease is so prevalent, but we don't want to be misled. This is essentially acute liver failure and requires consideration for the differential of acute liver failure. In terms of diagnostic criteria, Swansea criteria have been used for research purposes. In terms of symptoms that stand apart from those of normal pregnancy, abdominal pain and encephalopathy should bring this to mind. On labs, hypoglycemia, grossly elevated AST, ALT, hyperammonemia, coagulopathy should also heighten our level of suspicion. And then on ultrasound, we're looking for ascites or hyperechoic liver. Histologically, we see microvesicular steatosis, different from fatty liver disease, which is traditionally macrovesicular. So basically, when a patient comes in with hypertension, the goal with labs is to determine whether this is preeclampsia or not, and if it is preeclampsia, whether it meets criteria for severe features based on symptoms or labs, and then to rule out preeclampsia imitators. So again, because creatinine decreases in pregnancy, the threshold for renal dysfunction, diagnostic for preeclampsia is a creatinine of greater than 1.1 or 2 times the patient's prior baseline. You'll also be looking at AST, ALT, and remembering here the criteria is 2 times the upper limit of normal. On CBC, we might see further hemoconcentration due to third spacing from increased hydrostatic pressure and decreased oncotic pressure from hyperalbuminuria in preeclampsia. You might also be looking at the platelet count to look for thrombocytopenia driven by increased platelet consumption, aggregation, microthrombi formation. Platelet count generally decreases in pregnancy, so the diagnostic threshold that we use, as I mentioned, is less than 100. Then you'll use a urine protein to creatinine ratio to look for proteinuria. Proteinuria increases in normal pregnancy, and this is because of increased GFR and permeability of the glomerular basement membrane, plus decreased tubular protein reabsorption. So pathologic proteinuria is considered greater than 300 milligrams per day, or a urine protein to creatinine ratio of 0.3 or greater, different than outside of pregnancy. Then in a patient who has intractable right upper quadrant pain, you want to be getting a right upper quadrant ultrasound to assess for subcapsular hematoma, hepatic or portovenous thrombosis. You want to ask for this with Doppler, and then also be looking for that right liver or ascites that we mentioned that we see in AFLP. You might also be using the right upper quadrant ultrasound or abdominal ultrasound to look for other pathologies of right upper quadrant pain or elevated LFTs. Then we might be getting a chest x-ray if there's any respiratory symptoms, given that preeclampsia can cause pulmonary edema. And in patients who have truly intractable headache or any focal neurologic symptoms, you want to be pursuing head imaging, as preeclampsia does increase risk of hemorrhagic and ischemic stroke, as well as PRES and RCVS. Depending on the clinical scenario, non-con CT head, CT angiogram of the brain, or MRI, MRA, MRV without contrast can be used in pregnancy. We generally do avoid gadolinium contrast in pregnancy. And then if you're considering HELP, you also want to be looking at that peripheral smear. We've already touched on the majority of these complications, but here are the many possible complications of preeclampsia. And again, I'm going to leave this slide more as a reference slide. In terms of management of preeclampsia, in my experience, medicine is usually called, as I mentioned, when blood pressure control is difficult or for seizure. So we're going to focus on management of these 2 areas. I want to reinforce here that severe range blood pressure is a blood pressure of 160 over 110 or greater, either number. And this is considered an obstetric emergency. It needs emergent treatment. It's not like treating chronic hypertension. Even if the patient is asymptomatic, it has to be treated emergently. And this is because these blood pressures are correlated with increased risk of seizure and stroke. The mainstay antihypertensives used in this setting are IV labetalol, IV hydralazine, or immediate acting oral nifedipine for patients who don't have an IV. Magnesium is used for seizure prophylaxis and controlling seizures in eclampsia. The dose is listed here, and OBs know this very well. This should be on code carts on obstetric floors, but if the patient, one thing to know is if the patient doesn't have IV access, you can give the magnesium dose intramuscularly, and that's also listed here. Also know that in an emergent situation, if you don't have magnesium readily available, or if there's uncertainty as to whether this is a preeclamptic seizure or not, you can go ahead and use benzos. Sometimes you'll end up using both, and that's fine. And then I just mentioned this last historical concern about nifedipine and magnesium together causing hypertension, so we know that it's not borne out. You can use them together. Here's an example regimen for the acute treatment of severe hypertension, and this is just a sample. It can be done in different orders. If you want to start with hydralazine, for example, in a patient that's bradycardic already or has severe asthma, or if the patient doesn't have IV access, then you need to start with nifedipine. So once blood pressures are out of the severe range with short-acting antihypertensives, we want to be sure to start oral therapies. And I tend to think of this a little bit like AFib with RVR, where you've not corrected the underlying problem. So you need to start an agent for longer acting control. The goal blood pressure in preeclampsia is controversial and varies between obstetric society guidelines from country to country. In the acute phase, lowering from severe range to 130s to 150s over 80s to 100s, and then subsequently targeting 130s to 140s over 80s to 90s with oral therapy is a reasonable approach. And this is because there's some thought that permissive hypertension is important for placental perfusion in these cases. And then postpartum, where placental perfusion is no longer a concern, I do like to keep patients on the lower end of the 110 to 140 over 70 to 90 range. In terms of longer acting oral antihypertensives, we often use more frequent dosing in pregnancy and postpartum because there's increased hepatic and renal clearance in pregnancy that doesn't normalize for several weeks postpartum. In terms of agents, nifedipine is most often used depending on the blood pressure. We can start with 30 milligrams extended release daily or twice daily and up titrate to a total of 120 milligrams a day. Labetalol is often started at a dose of 200 milligrams 2 times or 3 times a day. It can be up titrated to a total of 2,400 milligrams a day, but really we see diminishing returns beyond 1,200 milligrams a day. And then captopril and enalapril are both considered compatible with lactation by the American Academy of Pediatrics, so can be used in that setting. And then hydralazine, I tend to only use in the acute setting, and methyldopa only if I'm out of other options, which tends to be in a patient who is maxed out on nifedipine and labetalol already, though we can use other agents like thiazide diuretics and other calcium channel blockers if they're not already on one. Again, key takeaways for preeclampsia: it's a multi-system inflammatory disorder. It affects pregnant and postpartum patients. Not all new hypertension in pregnancy is preeclampsia. Severe hypertension needs to be treated emergently with fast-acting antihypertensives. Generally, IV antihypertensives need to be followed by long-acting oral antihypertensives. Magnesium is for seizure prophylaxis and treatment, not for blood pressure control. And pregnancy-related hypertension can persist for up to 12 weeks postpartum. Next, we will talk about pyelonephritis. So pyelonephritis is estimated to affect 0.5% to 2% of pregnancies, higher than in the general population for a couple reasons. Progesterone causes smooth muscle relaxation, ureteral dilation, and urinary stasis. That's exacerbated by pressure on the bladder and ureters from the uterus. And then there's higher incidence of nephrolithiasis in pregnancy, which can act as a nidus for infection. In terms of clinical features, most cases happen in the second and third trimesters when those factors I just mentioned come into play. And this piece is really important. Pyelo is often not preceded by recognized symptoms of cystitis. Generally, presentation includes fever, nausea, vomiting, flank pain, CVA tenderness. In terms of microbiology, organisms that cause pyelo in pregnancy are similar to those outside of pregnancy. Then it's important to keep in mind that roughly 20% of patients will have coexisting structural disease like obstruction. And as always, as a medical consultant, it's important to have a differential when someone's calling for presumed pyelo. Traditionally, OBs are really comfortable taking care of this in pregnancy, so something is up if they're calling. We should think about the other causes listed here. These last two causes are circumstances in which symptoms and signs might be overcalled as pyelonephritis, which is actually what we generally want to do rather than undercalling because of the risk to a pregnancy of untreated pyelonephritis. But one episode of pyelo in pregnancy does buy a patient antibiotic prophylaxis for the rest of pregnancy and a few weeks postpartum, so accurate diagnosis is important. These last two typically occur without fever, and that's sort of the biggest differentiator. These diagnostics are all fairly intuitive. I'm going to highlight just a few differences. So we want to remember that asymptomatic bacteriuria is treated in pregnancy because of the risk of progression to pyelo. Lactic acid reference ranges are unchanged in pregnancy with the exception of during labor when the upper limit of normal is 4. And then on renal ultrasound, it's important to remember that there is physiologic hydro in pregnancy, often right kidney greater than left. So we need to look for presence of ureteral jets to figure out if there's obstruction, true obstruction. In terms of management, all pregnant patients with pyelonephritis should be hospitalized for IV antibiotic therapy until they're 48 hours afebrile and symptomatically improved. Empiric antibiotic choice for pyeloid pregnancy includes broad-spectrum beta-lactams, with the most common choices being ceftriaxone, piptazo, and cefepime. Ampicillin, aminoglycoside-containing regimens like ampicillin, gentamicin are less preferred because of concerns about ototoxicity with certain aminoglycosides. And if the patient has a history of ESBL, carbapenems can be used, with first choices being Miro or ertapenem. And if the patient has a beta-lactam allergy, we can consider aztreonam. And of course, we want to be making this choice based on the local antibiogram and patient's prior culture data, if available. So when culture data returns, antibiotic therapy can be tailored with a switch to orals after 48 hours without a fever. Historically, a 10 to 14-day course has been recommended. More recent data in non-pregnant populations suggests shorter courses are comparable to these longer courses. But because we're often using beta-lactams in pregnancy, which don't have as long of a post-effect, we tend to complete at least 10 days. Beta-lactams are still preferred, though Bactrim can be used if the patient is in their second trimester. And we want to keep in mind that patients need a test of cure at the end of treatment. Recurrence is fairly common, and so this is why I mentioned we use low-dose antimicrobial therapy as prophylaxis for the rest of pregnancy and for 4 to 6 weeks postpartum with the choices listed there. Okay, after a day or 36 hours, you might be saying, but she's still febrile. So here are a few things to know. Antibiotic failure is not particularly common in pregnancy. About 2.2% of pregnant patients admitted with pyelo have antibiotic failure. And this is because of lower rates of resistant organisms in this population. But pyelo is extremely inflammatory in pregnancy. We should see the fever curve starting to bend, but it often takes a true 48 to 72 hours of appropriate antibiotic therapy to see significant improvement. So defined as 75 to 95% of patients will be afebrile for a 24-hour period within 48 to 72 hours of antibiotic initiation. That being said, up to 20% of patients may develop complications. And so let's review what those might be. So you're all familiar with perinephric or renal abscess. And here we just want to keep in mind that pregnant patients can undergo IR procedures if the lesion's amenable. In terms of obstructing stones, we might have heard that lithotripsy can't be performed in pregnancy, and that's true that extracorporeal can't be performed, but intraureteral is actually okay. And then in my training, I was surprised to discover that pulmonary edema, respiratory insufficiency, occurs more commonly with pyelo in pregnancy. So up to 7% of patients can develop ARDS. And if it's primarily pulmonary edema, it often responds well to a low dose of diuretics. We want to be treating sepsis and septic shock the same as we would in non-pregnant patients. And we want to keep in mind that there are certain obstetric risks associated with pyelonephritis. And of course, those would be managed by the OB team. A common question that comes up is about general antibiotic guidance in pregnancy. So here, we should be thinking along a spectrum of medications that are justifiable or not, depending on the clinical circumstance. A lot of the information about safe use of antibiotics in pregnancy was from decades ago, before pregnant women were excluded from drug studies. So there's really not much direct information about safety of newer antibiotics, and concerns mostly come from indirect evidence, like animal studies or observational studies with lots of confounders. Overall, we tend to use the antibiotics that have better established safety profiles and limit use of antibiotics of potential concern to cases where there's no safer alternative. So this is just a breakdown of some of the more common agents in broad buckets for your reference. And I'm going to use this opportunity to sort of return to a general principle that we're weighing the risks of untreated or suboptimally treated medical condition, which can have negative maternal and fetal effects against the risk of medication exposure. So here, untreated pyelo, obviously a big risk versus the risk of appropriate antibiotics. And then while we're talking about medication safety, I want to emphasize that the old FDA letter grading system for pregnancy has been phased out because it supported this false dichotomy of safe versus not safe and didn't accurately communicate certain fetal risk, but also didn't take into account the risk of withdrawing or withholding appropriate treatments. So the FDA has replaced the system with risk narratives that facilitate risk-benefit discussion between patients and providers. Okay. Here are some helpful links to different sources of information about medication risk in pregnancy and lactation. So Terrace and Reprodox are unfortunately paid. LactMed is free. And then you might have access to some of these resources through your own institution. For example, we have access to Briggs online. All right, summary slide for your reference. Pyelo is more common among pregnant patients than in the general population. Pyelo in pregnancy is often not preceded by typical cystitis symptoms. Broad-spectrum beta-lactams are appropriate empiric treatment. You want to be choosing based on local antibiogram and prior culture data. Treatment of sepsis in pregnancy is the same as in non-pregnant patients. Pyelo in pregnancy is inflammatory. Complications are common, including respiratory failure. And we want to maintain a low threshold to get renal ultrasound to look for obstruction or perinephric abscess. Next, we will talk a bit about pulmonary embolism. So PE accounts for 10 to 15% of pregnancy-associated mortality in high-income countries. The overall incidence is 0.45 to 2 per 1,000 pregnancies, which is about 4 times that of non-pregnant population, and it's more common postpartum. The presentation of PE in pregnancy is often more subtle, partly because there are overlapping signs and symptoms of physiologic changes of pregnancy and PE, so tachycardia, lower extremity edema, and dyspnea. And there is a left leg predominance for DVT because of the anatomy of the vasculature of the lower abdomen and pelvis together with the expanding uterus. While pregnant patients were excluded from the PIOPED-2 study looking at PE symptoms in the general population, small retrospective cohort studies suggest that PE symptoms in pregnancy are similar to those in non-pregnant patients. And so an observational study from the UK that included 198 pregnant or postpartum women with diagnosed PE, dyspnea at rest was reported in 54%, pleuritic chest pain was reported in 52%, cough in 9%, and hemoptysis in 7%. So how do we diagnose PE in pregnancy? So as you all know, in non-pregnant populations, we rely on sequential assessment of clinical pretest probability, often using specific algorithms, then measurement of plasma D-dimer levels, and then potentially imaging studies like CTA or VQ scan in selected cases. But historically, none of our typical pretest probability generating tools had been designed or studied in pregnant populations. D-dimer testing was traditionally thought to be unreliable in pregnancy because D-dimer rises in normal pregnancy. And then, of course, there's concern about exposing patients to radiation in pregnancy with imaging studies. But as it turns out, because signs and symptoms are so nonspecific in pregnancy and we don't have as many tools for determining pretest probability or lab testing for rule out, we may be missing cases or unnecessarily imaging. So what diagnostic tools do we have? Let's briefly go through these. Pulse oximetry, of course, not sensitive or specific. Just a quick note here, in pregnancy, supplemental O2 is started for O2 sats less than 95%. ABG, again, not sensitive or specific. It's important to note that respiratory alkalosis is a common feature of both normal pregnancy and PE. And then EKG, sinus tachycardia is very common in pregnancy and can be normal up to 120 beats per minute at rest because of increased cardiac output and therefore heart rate. Chest X-ray is helpful for looking for an alternative explanation for shortness of breath in the parenchyma, or if we plan to get a VQ scan. Otherwise, it's obviously not sensitive or specific for PE, but some providers do advocate for getting this as sort of a first pass in all patients. And D-dimer rises over the course of normal pregnancy, as I just mentioned. We know the limitations of lower extremity ultrasound, so absence of a VTE doesn't mean much. And in pregnancy, VTE at or above the common femoral vein is more common. And then there's chest imaging, so VQ scan or CT-PA, and a 2017 Cochrane systematic review. Both of these had 100% negative predictive value in pregnancy with higher sensitivity on VQ scan and fewer inconclusive results. But this data was from older studies using older CT technology. Newer studies using improved CT technology suggest CT-PA is diagnostically more useful in pregnancy than it has been in the past. There are advantages to CT-PA, including information about the lung parenchyma, which can offer an alternative diagnosis in up to 13% of cases. And it also has relatively low dose of fetal radiation exposure. We'll talk a little bit more about that. And there's better availability than VQ scan. quick side note, I mentioned we'll talk briefly about radiation exposure in pregnancy. Yes, we know radiation in high doses can lead to the complications listed there on the left in terms of fetal complications, but there's no evidence of adverse effects from exposures less than 5 rads, which is 50 milligray. And almost all commonly used diagnostic imaging involves radiation exposure well below 1 rad or 10 milligray. So we see here that CTA of the chest has a fetal radiation exposure of 0.01 to 0.5 milligray. And we can compare this, I think it's helpful for patients, to the sort of natural background radiation exposure for a fetus through gestation, which is about 1 milligray. Even so, many patients and providers want to avoid imaging, and there have been 2 large prospective studies published over the past 5 years to try to adapt PE algorithms to pregnancy. And we're going to focus on the pregnancy adapted years algorithm because this was conducted in a hospital setting rather than the other one, which was the revised Geneva score that was done in the outpatient setting. So the pregnancy adapted years algorithm was a prospective study of 498 pregnant women with suspected PE. They used the years algorithm, which is a combination of 3 items that we can see here in this MD-Calc screenshot on the right: clinical signs of DVT, hemoptysis, or where the treating clinician considered PE to be the most likely diagnosis. The years algorithm with 1 modification for pregnancy was used plus D-dimer to exclude PE. If PE could not be excluded, the patient underwent a CTA. Their primary outcome was the number of VTE events during the 3 months of follow-up, and their secondary outcome was the number of patients who required CTA. Here's the diagnostic algorithm. They first looked for the presence of the 3 years criteria we just went over. If there were signs of DVT, the patient first underwent compression ultrasound of the symptomatic leg. This was the pregnancy modification. And if this was positive, anticoagulation was started, no chest imaging was done. For all those who did not have clinical signs of DVT or those who had negative compression ultrasound, they then excluded PE in patients who had 0 years criteria. And a D-dimer of less than 1,000, and also considered PE excluded in patients who had 1 or more years criteria and a D-dimer of less than 500. All other patients were referred for CTA. So how did the algorithm perform? PE was diagnosed in 4% of patients in the cohort. CTA was avoided in 39% of patients who would have otherwise gotten it. And only 1 patient who was not initially diagnosed with VTE was diagnosed with DVT in the 3 months of follow-up. No patients were diagnosed with subsequent PE during follow-up. The efficiency of the algorithm was highest in the first trimester and lowest in the 3rd, as we might expect given that D-dimer rises as gestation advances. So let's assume that you diagnose PE. In terms of management, low molecular weight heparin is the agent of choice in pregnancy. Dosing is the same as in non-pregnant patients. The 2018 American Society of Hematology guidelines also say that 1.5 mg per kg once daily is okay, but we tend not to use that as much because of the increased renal clearance of pregnancy. It doesn't seem to make as much physiologic sense. Sub-Q unfractionated heparin is generally less preferred, as it is in non-pregnant patients, unless the patient has renal insufficiency. Treatment duration and intensity are not well established in pregnant populations. Recommendations really vary by society to society, so between CHEST, ACOG, and ASH. Generally, some recommendations allow us to step down to intermediate dosing, so 1 mg per kg daily, or prophylactic dosing after 3 to 6 months of full dose treatment to be continued for at least 6 weeks postpartum, while others recommend continuing 3 to 6 months of full dose anticoagulation or until 6 weeks postpartum, whichever one is longer. And in practice, we tend toward this latter recommendation, but decide on a case-by-case basis. Planned induction is recommended for patients who are on therapeutic anticoagulation for timing of anticoagulation discontinuation. And then we don't have enough safety data about direct oral thrombin and 10A inhibitors in pregnancy, and some data of harm with agents like rivaroxaban. So we can't justify their use, and that's the same case with lactation. Coumadin is generally avoided in pregnancy. It's a known teratogen, but can be used in breastfeeding. In terms of additional peripartum considerations, when PE is recently diagnosed, you might want to think about a retrievable IVC filter and or a heparin bridge after stopping low molecular weight heparin around delivery. And then, of course, there are other circumstances where you might consider these options depending on the risk associated with each patient's clot and clinical circumstance. Sometimes deliveries will need to proceed with full anticoagulation and alternative sources of pain control other than neuraxial anesthesia. Otherwise, guidelines recommend neuraxial anesthesia should not be placed within 24 hours of the last dose of therapeutic anticoagulation, then can be resumed postpartum with timing dependent on the delivery. So 12 hours after C-section and 6 hours after vaginal delivery, assuming no significant bleeding has occurred, and also depending on whether the patient received neuraxial anesthesia. There's a great link here at the bottom to timing of anticoagulation around neuraxial analgesia from Stanford. And then there's controversy about in which clinical circumstances evaluation for thrombophilias should be performed. Recent ASH guidelines suggest testing in all patients with VTE diagnosed in pregnancy. We don't have enough time to get into that, but here's a reference table that shows changes to different components of the coagulation system in pregnancy. So keeping in mind that generally for non-molecular testing, if testing is pursued, it's ideal to wait until at least 3 months postpartum after breastfeeding and after stopping anticoagulation. So key points here, PE is more common in pregnancy, postpartum compared to the general population. It remains a leading cause of maternal morbidity and mortality. Signs and symptoms have overlap with physiologic changes of pregnancy. Benefits of imaging often outweigh risks in patients with suspected PE. There are emerging algorithms that allow incorporation of D-dimer testing for pregnant patients, and low molecular weight heparin is first-line treatment. We will briefly talk about procedures in pregnancy. So, of course, it's impossible to address all potential procedures that might be needed during pregnancy. We're going to go over general principles and skip straight to key points. So, pregnant patients should never be denied or have delayed medically necessary surgery, regardless of their trimester. This can, of course, adversely affect the pregnant patient and the fetus if a necessary surgery is delayed. Elective surgery should be postponed until after delivery. No currently used anesthetic agents have demonstrated teratogenic effects in humans at any gestational age when used at standard doses. There's no evidence that in utero human exposure to anesthetic or sedative drugs has effect on the developing fetal brain, and animal data support no effect with exposure limited to less than 3 hours. When the care team is considering a non-obstetric surgery, the primary OB care provider should be involved. Fetal heart rate monitoring may help with maternal positioning and cardiorespiratory management. It may also influence obstetric management depending on the fetal age and viability. Screening for VTE risk and giving appropriate perioperative thromboprophylaxis is important to do even in your pregnant patients. Lastly, we're going to talk, this is a new request this year, to talk a bit about diabetes. So we're going to touch ever so briefly on this. So management of diabetes in pregnancy is different than outside of pregnancy. Inpatient management should include endocrine consultation because of these sort of important differences. It's important to know that insulin resistance increases over the course of gestation, often week over week, requiring fairly aggressive and persistent titration in antihyperglycemics, generally insulin. Glycemic targets are much tighter in pregnancy. So we target a fasting blood sugar of 70 to 90, a 1 hour postprandial of 110 to 140, and a 2 hour postprandial of 100 to 120. Then, as sort of mentioned with the glycemic targets, a measurement of blood sugars in pregnancy is different. We tend to check fasting 1 or 2 hours postprandial, and then nightly before bed. Sometimes patients do check premeal, especially if their mealtime insulin is based on their premeal blood sugar. Insulin is first-line treatment in pregnancy. Metformin is used in select cases. All right, so then we'll talk, this is supposed to be animated, so this says pre-pregnancy type 1 diabetes and type 2 diabetes, and the other, this other box says gestational diabetes. So we're going to focus on a few features unique to pre-existing diabetes in pregnancy. We're not referring to gestational diabetes, which is diabetes diagnosed during pregnancy related to insulin resistance of pregnancy in patients who don't have overt diabetes prior to pregnancy. So we're going to focus on pre-existing diabetes now. So we want to be mindful that DKA occurs in up to 3% of pregnant patients with pre-existing diabetes. It mostly happens in patients with type 1 diabetes, but can happen in type 2 diabetes, especially those who are ketosis prone. It happens at lower glucose levels in pregnancy. And so this is one of the cases where we can see euglycemic DKA. And up to 30% of patients have blood sugars less than 200 at the time of diagnosis. It most often happens in the second and third trimesters, but can happen in the first. Symptoms in pregnancy are similar to those in non-pregnant patients, but do have overlap with common pregnancy symptoms. Triggers are similar to those in non-pregnant patients, but we also want to keep in mind a few specific to pregnancy, so giving systemic steroids for fetal lung maturity, and then certain tocolytics. Lab findings are similar to those in non-pregnant patients, but again, we want to pay attention to a potential hidden metabolic acidosis in the setting of what we talked about, known physiologic respiratory alkalosis of pregnancy, and then hidden anion gap given low albumin levels in pregnancy. DKA is considered an obstetric emergency. It can result in fetal hypoxemia, acidosis, fetal mortality, also maternal morbidity, and rarely mortality. Another important little pearl in diabetes and pregnancy is that insulin requirements decrease rapidly and substantially after delivery. So in patients who were on insulin prior to pregnancy, we generally use 60 to 70% of their pre-pregnancy dose after delivery, with half of that given as basal insulin. Alternatively, if we don't know their pre-pregnancy dose, we can use 30 to 40% of their most recent pregnancy insulin dose, their total daily dose, and again, half of that is given as basal insulin. And then, of course, this can vary significantly from person to person, this requirement in the postpartum period. So it's important to really closely monitor and quickly tailor therapy. If patients were not on insulin prior to pregnancy, they generally do not need insulin in the postpartum period. We can, however, safely resume metformin during lactation. So key points here, endocrine consult is appropriate for pregnant patients admitted with pre-existing diabetes. Treatment targets for blood sugars in pregnancy are much tighter than those in your non-pregnant patients. Blood sugar monitoring in pregnancy is different than in non-pregnant patients. DKA occurs in type 1 and type 2 diabetes in pregnancy and at lower blood glucose levels. DKA is an obstetric emergency, and insulin requirements decrease rapidly and substantially after delivery. With that, I'm going to return to these 5 general principles about caring for pregnant patients and hope that you all feel a bit more empowered to take care of this patient population. Here are my references. Thank you.